Hello, everyone, and welcome to a WEDI special virtual spotlight, preparing state Medicaid for CMS-0057-F, what implementation looks like, sponsored by Itiliti Health. It's my pleasure to introduce WEDI's Executive Director, Robert Tennant.
Thank you, Michael, and let me add my welcome. This is the second event that we have held to focus attention specifically on the unique needs of the state Medicaid agencies, and we're really pleased that we have a blue ribbon panel of experts to help you all navigate this challenging regulation. So just for those that maybe are not familiar with WEDI and who we are and where we came from, we stretch all the way back to the first Bush administration, where then HHS Secretary Dr. Lewis Sullivan, who was a practicing physician and knew firsthand some of the challenges that physicians and health plans face in exchanging data, he convened what he called the Working Group for Electronic Data Interchange and charged them with developing reports on how the industry could better utilize electronic standards and work collectively to develop approaches for identifiers, and of course for the guardrails of health information exchange, privacy, and security. So that working group developed two reports in 1992 and 1993 that actually included legislative language. They were then folded into the Health Insurance Portability and Accountability Act, which was passed in 1996, and WEDI was named in HIPAA as an advisor to HHS, and we've continued that role ever since then. Our mission is very simple and clear. We are here to convene and educate. Our goal is to bring together those key stakeholders, whether they be health plans, providers, vendors, clearinghouses, standards development organizations, federal and state government. And now we're even broader in that we include patient advocacy groups as well. As you can see here, we have two major roles, part of which you'll see today, and that is to convene, to bring folks together to talk, to come up with solutions. And a big part of how we do that is through our work groups, which I'll touch on in a minute. But we're also an advisor, as I said. We are named in HIPAA. We have things like member position advisories where we bring our membership together to discuss perhaps proposed rules or requests for information and come up with consensus-based recommendations that we include in our comments and letters. Next slide. So as I mentioned, a big part of what we do is educate, and the session you're involved with today is an example of that. We have specifically focused attention on the CMS interoperability and prior auth final rule, better known as the CMS 0057 final rule. We've held probably 3 or 4 dozen different educational events since the rule was released in 2024, and we continue throughout this year to bring you education to help you navigate this particular regulation. Next slide. As I mentioned, we have a very robust set of volunteers that work through our work groups, and we've got work groups on all of the major HIPAA transactions, as well as issues such as genomics and emerging technologies. We also have one on the No Surprises Act, and we've just recently stood up a work group focused on the patient experience and how health information technology can improve the care delivery process and how patients interact with their health plans and their providers. Next slide. So today's agenda, after my welcome, we'll turn it over to our good friends um, from CMS to talk about the rule and provide their update. We'll then turn it over to our sponsor, Itiliti Health, to give a technical walkthrough for those that are seeking a little bit more information about this rule. They'll then dive into what our surveys have shown is one of the most pressing issues with this rule, and that is digitizing policies, really the cornerstone for what this rule is attempting to do. And again, a big sponsor. We've had a wonderful relationship with Michael and Itiliti Health, and they've been a wonderful partner with WEDI over the last 2 years or so. So I encourage you to reach out through their website and find out exactly the services that they offer. So because I suspect they can help you as they're helping others in the industry. We like these events to be as interactive as possible. We encourage you to ask questions, to make a comment, to post things, you using the chat feature. And as we always do with these types of spotlights, we'll send you the slides and recording after the event so you can share them with your colleagues. And with that, I'm pleased to turn it over to David Koppel, who is Director of the Division of Policy and Operations, the Office of Healthcare Experience and Interoperability at the Centers for Medicare and Medicaid Services, and Scott Weinberg, who is an advisor at the Division of Policy and Operations, Health Informatics and Interoperability Group at the Office of Healthcare Experience and Interoperability at CMS. So David and Scott, I'll turn it over to you.
Sure. Yeah. So thank you, Rob. I'll start us off, and I will go take the screen here. Just a second. Okay. Great. So thank you, and thank you, WEDI and Itiliti for this convening. I knew that WEDI had done a lot of education on 057F, 3 dozen about what Rob said. Sounds about right, and so we're happy to usually be a part of those. Um, so for those who don't know, I see a lot of familiar names on here, but if you don't, David and I, we are from the Office of Healthcare Experience and Interoperability at CMS, specifically in the Health Informatics and Interoperability Group. So, those of you in the industry were the ones who published the interoperability rules. The first one being uh, from 2020. Uh, uh, and which we refer to as usually interop 1 or the 2020 final rule. And we're the ones, we really, our mission promoting that the secure exchange, access, and use of health information to support better informed decision making, more efficient and a more efficient healthcare system. This slide here is kind of our 10,000 foot look at the technical requirements of 0057F, the API requirements. I understand Itiliti is gonna go through those, go through more of the technical details. I'm glad they are, because I will not be here. But here we have our 4 APIs. The patient access API, which was established in that aforementioned 2020 final rule. And then the provider access, the pair-to-pair, and the prior authorization API, which are brand new, finalized this rule. The patient access API, which is currently active, we hope, but currently required, at least, that enables the secure exchange of claims and encounter information, but so a patient can access it from their own third-party app, using that API directly from the payer, to see from the very simple basic workflow here. This rule added prior authorization information for items and services, not drugs, and then established the provider access API, which enables the exchange of that same information, except for cost sharing information and provider remittances. And in addition to the payer-to-payer, which meant to exchange enable bidirectional exchange. You see from this double arrow between two different pairs, and then the prior auth API, which is less about exchanging that claims and encounter information, but more enabling a prior authorization, and information about prior authorization. I'll go into that a tiny bit more detail. Now I know on the I think the agenda says CMS updates. I think we're not really here so much to update as to remind, because we have deadlines that have either passed or fast coming up. And so as I mentioned, the patient access API, what was finalized was adding information about the patient's prior authorization into this already established patient access API. So beginning January 1, 2027. The other thing that is now currently active, and that deadline is coming up end of this month, is to report usage metrics in the form of aggregated de-identified data about usage of the patient access API. This is so we can just monitor how often is this being used, who's using, and really this the basic effectiveness of this API. So that became effective beginning of this year, and different programs have different ways they'll be reporting this. We did recently update our FAQs on our website. There's a very nice chart that shows by program who to contact for questions, and basic information on how to report these. So if you haven't seen that, I encourage you to take a look. We could probably also put that in the chat. Now, I mentioned these fast approaching deadlines. I think the last WEDI webinar on this was called the final countdown. Why is it important to try and meet these? It's not because it's not just these technical requirements of standing up these APIs, but there are non-technical processes involved. So in addition to so for like the provider access API, this is to enable exchange with in-network providers with whom a patient has a treatment relationship. And so while the API needs to exchange the data that we outline here, there are processes that are required to ensure that this data, the data are only going to a provider that has a treatment relationship with the patient, established via an attribution process, which we were purposely not prescriptive on in the final rule. But this process should associate patients with their providers, just to make sure that data is only sent to providers who have that treatment relationship. And then patients also do need to be given the ability to opt out of this data exchange if they choose to. So and once again, we weren't prescriptive on how this we weren't very prescriptive on how this opt-out process should work, but those are kind of the supporting processes for this API to ensure that the data are going to who they're supposed to be going to. Kind of similar to the payer-to-payer API, which at a high level is enabling the exchange of that same that's the same claims and encounter information and the US CDI between a patient's payer and their new payer, or two concurrent payers. Some other data requirements is that they would have to exchange all the data they have within 5 years, the data service of the request from the patient to exchange that data. And then this also does require patient consent to exchange data, but this is an this is an opt-in mechanism, so the patient would need to opt in to sharing that data. So for both of these APIs, provider access and payer to payer, again, another a non-technical but important process to be established is these educational resources. So for the provider access API, the patients and providers should need to be provided information in plain language about the benefits of API data exchange. For patients, the information about their ability to opt out of that exchange if they so choose, and for providers, information about the process for requesting patient data, and then as well as being open about what your attribution process is. And then similar for the payer-to-payer API, again, plain language materials to the patient about the benefits of data exchange between pairs, and then their ability to opt in or withdraw a previous opt-in decision, and then as well as instructions for doing so. On our website, we have a document outlining best practices for designing these resources. I may have mentioned, but I'll mention again, we were not prescriptive in the rule itself, and on our website, our best practices those are just suggestions, but ways really to make sure your patients and the providers understand kind of what all this is. And then finally, the prior auth API. So this is the API that should be populated with a list of items and services, again, excluding drugs that require prior authorization. It also does need to be able to identify your documentation requirements for all items and services, and then also the ability to just do the prior authorization itself, really just enabling a provider from their EHR to request and receive prior auth and receive that decision. Now, in addition to those technical pieces, the APIs, the other kind of large piece of the rule was the improving prior authorization processes. Shortening decision timeframes, so standard request to 7 calendar days and expedited request to 72 hours. Those went into effect at the beginning of this year and are in effect right now, in addition to providing a specific denial reason if a prior auth request is denied. Then the other piece is publicly reporting prior authorization metrics. The deadline for doing that on your public website is January 31st, at the end of this month. This slide, I won't go through it all, but these are the specific things that need to be reported again by March 31st. So a list of items and services that require prior authorization, and then the various metrics aggregated for all items and services. So here is just a summary of the reporting levels for the various programs. Being mindful of the audience here, this is just Medicaid and CHIP listed here, but Medicare Advantage and the qualified health plans on the federally facilitated exchanges also have requirements, but as you see, reporting at the state and plan level as the program listed. And then reporting these metrics. Now there are requirements. So here highlighted are the metrics that are technically optional, but we strongly encourage them, just for transparency's sake and be helpful to the public. But when reporting, as you see in the red, our suggested denominators for reporting your overall approval and denial rates. So for standard prior authorization requests, so the requirement being to respond within 7 calendar days, it should largely be out of total requests. When it comes to extensions, we we do want to, we'd like to see approve. It would be helpful, at least to everyone, to see approved within 7 days. Or if there was an extension, what's the percentage approved after that extension? Part of the requirement is also to report appeals metrics, so the percentage approved after an appeal. Our suggested denominator for this is total appeals, because the reasoning being it's helpful to we think it would be more helpful to know just how often an appeal is successful. So the percentage denied after appeal is not strictly required, but if you are going to report the approved after appeal, we strongly recommend uh, reporting the denied also. And then finally, just publishing your response time. So the average, the median, and then as for clarification, these response times should be measured from when you receive the prior auth request to when the determination is sent. And this goes, the same thing goes for expedited requests, again within 72 hours. And out of total requests for overall approval and denial rates, extensions, appeals. For expedited, we did not strictly require appeals data, but if you're going to be doing it for standard, we again strongly recommend you do it for expedited requests as well. So just a quick example of your time measurement for response times. It's calendar days and hours, not business days. Also include weekends and holidays. And standard requests should largely be reported in days, and expedited in hours or days. So we do have a overview and template on our website. You may have seen this, but this is not required to be used, but we think it's just a good way to visualize the data. We've actually already seen some carriers report this, and some have opted to use the template, but some haven't. But but this is just a suggestion. In addition, Medicare fee-for-service also does do a prior auth stat report that's also public, and you can feel free to use that as an example as well. And so this chart is just kind of an omni chart of compliance dates, deadlines. As I went through all of these, but you'll get a copy of these slides. This is just a good overview. And finally, you probably all know in the unified agenda, we do have the next rule, the interoperability standards and prior authorization for drugs proposed rule. So as I mentioned, everything I talked about applies to items and services. And so we got a lot of feedback about why we left out drugs, and this rule will be addressing that. So keep a lookout. And then our website has a lot of these resources that I just talked about, but then if we have any time for questions, or we could take them in the chat.
Scott, David, thank you so much. We do have one question in the chat from Travis. For the PA metrics, any direction on partial authorizations? I see approval and denials in your numerator and denominator, but nothing about partials.
Yeah. David, do you want to?
Yeah, sure. So we do not have specific guidance on that. We know that it is a topic of discussion. And at this point, our guidance is to allow payers to report those as they feel is appropriate, with any notations in the report that explain how partial appeals or denials were categorized. Acknowledging that it is a very difficult question, which is why we have not been able to put out specific guidance. Sometimes there are arguments that anything denied is a denial. But also if 90% of something is approved and the last little piece, they're like, well, let's see how everything else goes. that is mostly an approval. We also don't, well, it's also an option for payers to report on line items rather than requests. But that will also, affect how other metrics are reported and how they may be interpreted by the public. So we are hopeful that at some point we will have some additional guidance, but I would not expect it immediately or imminently because we are working on that. So at least for this year, I would say we are leaving that up to payers to express in their reports in a way that makes sense for them.
Excellent, thank you. Additional
Yeah.
questions, and we'll hold a couple of questions, and I'm sure that David and Scott will make themselves available in the chat as we continue with the rest of the spotlight. Partha has a question. What is the guidance on determination made? Is it based on notification sent?
Yes, I guess.
Yeah.
Yeah. If
When it's sent back to the provider.
to
Yeah.
the provider
Mm.
or the patient or whatever the notice requirement is, because those notice requirements, I'd have to look it up, or the decision timeframes are tied to notice, of course. A payer can't just make a decision and not notify the applicable parties. So yes, so it should be based on notification going out, I guess.
Excellent. And the final question, and there are some additional questions in the chat that I welcome Scott and Dave to address. For the PA metrics, did the slide say that this metrics, excuse me, let me repeat that. For the PA metric, did the slide say that this metric would be of total appeals and not total requests? The percentage of standard prior authorization requests that were approved after appeal.
Scott, I think
Yeah, so I think that so
sorry.
I'll bring it back up 1 second. Yeah, so for appeals, we are suggesting that it should be out of total appeals. Let me get that up for you.
And I think the justification there is really to understand how often appeals are, or how often decisions are overturned or upheld upon appeal.
Yeah.
So that's really why, but we also recommend, that's why we're also recommending like raw count so that
Yeah.
people can see, appeals, maybe 75% of appeals were overturned, but appeals were only 1% of the decisions. And obviously I'm making up those numbers, but that's why we're suggesting raw numbers to actually give people a sense of what the denominator is.
Thank you. And as I mentioned, we do have some questions in the chat, and I welcome Dave and Scott to stick around and address those. And for the folks participating or attending this event, yes, the recording and the slides will be sent to all registrants post-event. So let's move on to our next presentation. It is my pleasure to welcome our folks from Itiliti Health. And once again, thank you to Itiliti for sponsoring this event. First up, the interoperability architect with Itiliti Health, Keith Brick.
Great. Thank you. It's a pleasure to be here and part of this great educational process. My goal is to make this look easy because after all, we're just connecting some APIs and they're RESTful, web-based. We're experts in that. But unfortunately, we need a few connections. For every hour it takes to make one connection, that's 250 years of full-time IT resources if we were trying to connect every payer with every provider. So obviously, we need the help of networks. So thanks to our concept of CMS line networks, our providers can hook their APIs up to intermediaries that will facilitate that discovery of, all right, for my patient, which payer am I reaching out to? which set of API endpoints am I actually going to route this data to? And I want to walk you through what this looks like in practice as we open up those black boxes of what's inside the payer that makes this work. So let's follow a provider. They've signed an order and their EHR has transmitted that CRD request. In this case, it's a order sign event, and it's going to go out to a CDS service endpoint, and maybe a CMS line network is helping them route this based on that patient's coverage. Inside of a CRD request, you have a couple of really cool things. You have a FHIR authorization that lets the payer come back and get more info if they need it. You have the patient's coverage and their draft order, the thing that the provider is trying to get for that patient approved. And all of this information is going to be sent over to the payer. And inside the payer, we have a lot of really cool tools. We have an API gateway that's going to be facilitating all of those payer-to-payer, patient access, and provider access APIs that we were shown earlier. And importantly, it's going to be a key part of our electronic prior authorization workflow, because we're not just submitting an order, we're going to try and go all the way through that prior authorization process, which means providing context about the care the patient has received. Some of that context might come from the provider's EHR, but it might already be in that data repository. Maybe it's member data that is from old claims files. Maybe it's member data that was received from another payer. But the important part is that for this to work, the provider needs to be able to get an electronic answer to, does this order require a prior authorization? So we're going to use the CRD API to find out what are the coverage requirements. And in that response to the CRD request, the payer needs an answer. It needs an electronic answer. And that's where a policy and questionnaire library comes in. That's the source of truth for the DTR process. So in our CRD response, we say, yes, this procedure needs a prior authorization, and in order to get it, we'll ask that you fill out this form, this questionnaire. Now, ideally, that questionnaire contains clinical query language that allows the provider's EHR to fill it out automatically, so that only a few questions, if any, need to be actually entered by a clinician or administrative assistant. But the reality is that today, we don't have all of our policies digitized quite yet across the nation. And so Michael will be talking a little bit more about that. The other thing that's going to happen as we are processing that CRD request is the payer needs to hold on to that information. They need to remember that context. The doctor's already told you what they're trying to order, and they've told you about the patient and their coverage, and they might have even, in the prefetch, sent over additional supporting information that might justify that, that order. If we get really clever with our integrations, it's actually possible to do an instant authorization, have enough information in that initial request to satisfy the criteria for that procedure. In that case, your policy library would be synced up with your utilization management system so that it could get that auth number and return it as part of the CRD response. And of course, you want to save all that data so that you can use it for the subsequent process, prior auth. All of that was set up answering the question of, does it need prior auth? And those are all the cool things we can do in that first step. But when it comes time to submit the prior authorization request, we still need the help of that intermediary in order to get our big bundle of supporting documentation, those questionnaires that we've answered, the documents that we've uploaded, the images or other FHIR resources that we've attached and submitted. And we're going to deliver all of that information to the payer so that they can make an informed decision about the prior authorization submission. If you have all of those policies digitized, then they can drive a rules engine. They can drive that automatic authorization process using clinical criteria that match up to codable concepts like SNOMED codes and LOINC codes that are present in that structured data you receive from the EHR. And of course, if that criteria is satisfied by information the payer already has, they might not even need to ask the provider to give it. After all, if you've already paid claims for physical therapy and the patient needs to have had physical therapy before they can have this procedure done, then you don't need to ask the provider for those physical therapy records. You know that the patient has received those. So that's why we have all of these pieces of the puzzle working together, is to accelerate this process as much as possible. And I don't want to leave out our delegated vendors, because the pattern that delegated vendors follow is actually very similar to how some of our state Medicaid programs might operate, where For a subset of the procedures that are paid by a commercial plan or Medicaid or Medicare plan, those rules might be handled by a third party that specializes in behavioral health or musculoskeletal care. And so we need to be able to use these same APIs, CRD, DTR, and PAS APIs, to exchange data and share that context and information with that third party. And we might be getting our electronic policies from the state directly. We might be sharing that final submission with the state so that they can review it and they can see, yes, this in fact matches our criteria that we've established at the state Medicaid level. So Michael will talk a little bit more about how we can help digitize those policies and make them useful in this way. But the important part is that all of this is driven on the ability to get a discrete answer, to submit data that is structured in a way that doesn't require extra work from the provider. It's automatically structured in that way as the provider does their work inside a certified EHR. And ideally, using those two pieces together, we can drive electronic authorization to give them an immediate response so that they're not waiting around for a phone call or a fax or a paper form in the mail in order for us to all be able to reach that 72-hour turnaround time in order to make sure that we're getting the patient the care that they need with as little delay as possible. So I'm going to pause right there. I can't see the chat. Do we have any questions that you'd like me to tackle right now?
I'm looking through here to see if there's anything related to your presentation. It looks like it's still the CMS stuff.
All right.
So
No worries.
please
I'll
continue.
be here in chat, happy to answer questions. And as we said, we're happy to share these slides. This is a generalized view of the ingredients that are part of this transaction. And this is just how we do a prior authorization at its core level. But we need things like a coverage requirements library. We need a policy and questionnaire library. We need a rules engine. We need tools that facilitate clinical review. All of those ingredients are tools that either need to be built from scratch or need to be upgraded to support these APIs by January of next year. So I'm sure we're all already working on it. All right, Michael, I'll turn it over to you.
Excellent. Thank you, Keith. Appreciate that wonderful technology detail on how this all works. I'm Michael Lunzer, CEO and founder of Itiliti Health. And my conversation with you today will be about the importance of digitizing policies and what actually is digitizing policies as well. So we'll start with talking about just, again, a very high level picture of the prior authorization APIs. And what Keith just described is that ultimately the payer, the state or the commercial or Medicaid, Medicare payer needs to have some mechanism, some system that is the source of truth for is a prior authorization required. What we find is many organizations don't have an efficient source of truth. So this is one of the pieces that is a critical component of implementing these prior authorization APIs. Another critical resource in this process is a system and a mechanism that can answer the DTR request, which is please send over the medical policy questionnaire or the clinical guideline questionnaire that helps the provider to know and actually submit the information necessary for a prior authorization request. And then the third element in this process is for the payer to have some system to receive those submissions from the provider. And so for today, talking very specifically about the policy, the digitization of policies, we'll focus in on the DTR transaction, which again is a scenario where the provider's EHR system is sending over a request to the payer saying, I need the questionnaire for this patient, for this procedure, on this date, with this type of coverage. At that point, the payer's responsibility is to send over a questionnaire. What is a questionnaire? A questionnaire in this context is really a mechanism for the payer to tell the provider or the provider systems what information is needed. Some of those things can be those requests or elements of that questionnaire can be in the form of a question. Some of the elements of that questionnaire might be more in the term of, please attach this document to this submission. And commonly, the questionnaire also incorporates the decision logic so that as the provider fills out that questionnaire, there's a possibility that depending on the payer's decision to do so, that the provider would immediately know that they have completed the required elements to get that approval and therefore go ahead and submit this approval and this request and it will be approved. So let's dive a little deeper into what specifically a questionnaire looks like and where does it come from? So specifically in this case, I'm showing a sample text from a medical policy, which is how these criteria or guidelines are typically organized for commercial payers. And we'll talk more about state payers in just a minute. But commercial payers typically have anywhere from 300 to 600 medical policies. And within those medical policies, there is specific guideline criteria. And on the left, you see the human readable version of that, the normal portion of a policy and the guideline that's buried within the 10 to 50 pages of medical policy from a health plan. On the right-hand side, you see the results of converting that typical text that shows up within a policy into a questionnaire that can be sent to the EHR. And this questionnaire is sent over in the form of a certain file type using FHIR, that when that EHR opens up that file, it looks virtually identical, regardless of which EHR system is opening this file, and allows that EHR user to be able to answer these questions. And again, as I mentioned, if the payer allows it to, that questionnaire can also tell the user as they answer these questions if they meet a guideline or a requirement. These questionnaires, as you see here, can also request specific documents be attached. Another component of these questionnaires is that they can also include codes, LOINC codes or other types of codes that are embedded within the questionnaire, such that when the electronic medical record system receives and opens this file, the electronic medical record system can go get and essentially answer the question rather than having a human have to physically check the box. So that's the makeup of a questionnaire. And again, ultimately, these one of the challenges for the state Medicaid organizations, both fee-for-service and the MCOs that support those state Medicaid offerings, is that there's a need to take those guidelines that are typically in a commercial organization inside of a medical policy, but inside of a state Medicaid organization, oftentimes they're in different types of formats. Many cases, they're in the form of a provider manual. And that means those are typically 1,000-page documents, sometimes multiple documents, multiple larger documents chained together. And within those documents, you have to really read hard to go find a particular policy or guideline for a particular procedure. Oftentimes, those policies and procedures in those guidelines, those provider manuals, don't have procedure codes, which is really the foundation of that transaction when the provider needs to send over a request for that questionnaire. The most typical foundational element is send me the questionnaire for this particular procedure code. So now we need a way to make sure that that provider manual that has maybe 1,000 pages, we go find all of the policy guidelines within those provider manuals and then convert them into something that resembles this FHIR questionnaire. And those can be yes/no questions, text entry questions, clinical measurement questions, and document attachments. So this is the ultimate challenge for the state Medicaid organization or an MCO. And again, the minimum requirement is we need to go in and find all of those guidelines within those policies and create fire questionnaires. The challenge is that if you only perform the minimum requirement, what ends up happening is you go create a fire questionnaire that somehow is loosely associated to that 1,000-page document and maybe a section in that 1,000-page document. And it makes it relatively difficult to ensure that you have the policy, the guideline in that 1,000-page document effectively linked and updated whenever the 1,000-page document is updated. The fire questionnaire needs to be documented. And then there's a user acceptance testing or a quality assurance testing that needs to take place in that process. So those are some of the challenges at trying to only create fire questionnaires and somehow link them to that 1,000-page document or many more pages. Some people might ask, is this a case for AI? Can I just point AI at my 1,000-page document and say, go find all of the guidelines that are buried in this document and create a fire questionnaire for each one of those? While that's technically capable, it actually creates a whole host of additional challenges. Specifically, the biggest challenge there is that those guidelines that are inside of those medical policies and provider manuals have been built over many years and tested to validate that they achieve the correct clinical outcomes and match clinical validity. So to be able to compare a AI created questionnaire to that written guideline in the policy or guideline becomes a challenge because AI may change some of the meanings or the organization of that data. So what we've found, and there are numerous solutions that can do this, is that the optimum solution to solving this problem is also the fastest, easiest, and most effective with the least amount of work. And essentially that solution is to replace the current process for a state of creating a policy in the form of provider manuals and following the commercial approach that's been used repetitively at most commercial health plans. And that is to essentially pull out those medical policies from those provider manuals, make them subsections that can be discreetly found easily, and linking those to procedure codes. And so again, this is that challenge that commercial payers already use these medical policies in discrete documents. State Medicaid agencies tend to bury those inside of larger manuals, and that also creates a workflow challenge. So just to give you an example of what that looks like, this is the Texas State Medicaid TM-PPM manual, which if you go to MCOs, managed care organizations within the state of Texas, many of them in their systems will say, if you need to perform a prior authorization request for a particular service, the rules are found in the Texas Medicaid Provider Procedures Manual. The challenge for that provider then is to go to this manual, and as you can see, it's quite large. It's got a table of contents, and it's topical by category, not by procedure code. And so there's a possibility that a procedure might be in more than one category. It makes it relatively difficult to navigate the procedures manual. And again, if I've got fire questionnaires that I need to link with subcomponents of this manual, there's a real challenge with keeping those things synchronized. The typical commercial health plan approach is that these medical policies are set up as discrete documents that ultimately can be used inside of an effective search engine that can search by procedure code, keyword, subprogram, policy date. There's numerous other ways to find the data. And this is what's really necessary when we talk about these fire questionnaires to be able to effectively find the right fire questionnaire for the right procedure and for the policy team to know that that fire questionnaire is linked to this actual document or section of the document. And again, by putting a new process in place, as changes are made to the policies, those associated questionnaires can be easily linked to the document that involves those fire questionnaires. So it's a much easier process of linking these two elements. And just to kind of refresh that point, the typical approach for a health plan is that they would, or a state, is that they have a work group that writes these documents. There's a physical movement of the document to an approval process, and then there's another physical movement of that document to a website team. So the opportunity here is to replace that with a system that helps integrate those processes, create a more efficient process, and at the same time helps streamline the process of creating those fire questionnaires and assisting in that alignment of a fire questionnaire to a medical policy and guideline. Another challenge that comes into play in the state Medicaid world is this scenario where states have multiple managed care organizations that, as I mentioned, are currently kind of referring to those policy manuals to find those guidelines. In the current world, what's been happening is we're seeing MCOs going about the process of going through those manuals, finding each policy and guideline, and creating their own fire questionnaire. And the unfortunate scenario there is if you've got, in the state of Texas, for instance, 19 managed care organizations that are all referencing the same Medicaid policies, it's really a shame if each of those MCOs have to go through the same amount of work to digitize and create fire questionnaires for those state Medicaid policies. So there's an opportunity here. The state Medicaid agencies can take the lead and create those fire questionnaires, pair them with their medical policies, make it easy for the MCO to absorb those fire questionnaires, and ultimately the states then get the benefit of creating those fire questionnaires for their fee-for-service marketplace, but also reducing the cost for state MCOs, which can be then passed back on to the state in the process. This is just a little bit of feedback we've seen from commercial health plans as they've gone about the process of replacing their document-oriented policy management system with something that unifies the fire questionnaire and the medical policy and brings those two things together. So there's a lot more workflow integration, standardizing of formats, tremendous efficiencies, automation of linking those CPT codes to policies makes it much easier to perform quality assurance on those fire questionnaires. And lastly, version control and scheduling. So when a new policy is created, if it's created as an independent document within a system, that document can be scheduled to be effective on a certain date. In the current model with states and their medical policies, the entire provider manual has to be updated each month, regardless of whether a section has changed. So there's a lot of efficiency ultimately that can come from taking a step back during this process and looking at a way to rethink the provider manual process, add efficiencies to ultimately save enough money to pay for that efficient system, and as a byproduct of that process, also get those fire questionnaires virtually for free in this process and deliver dramatic savings for the MCO marketplace. So again, this is a huge opportunity for state Medicaid organizations. Just a couple of quick things about Itiliti Health. We are focused on prior authorization. We've been in business since 2018. We have the solutions for each of those different endpoints. And what makes us unique is that we've been doing this for many years. The systems that health plans use to manage policies and rules are systems that our customers have been using for many years. We're essentially now adding fire APIs to those systems. So that concludes my portion of the presentation on a deep dive of digitizing medical policies. I don't know if there are any questions, and if we have time for those questions at this point, Michael?
I think Keith is doing a good job picking the questions off the chat for you.
Okay,
So I
great.
think, let me see, let me scroll through. Oh, we have one from Lin Nguyen. When PAs are coming in from the EHR from a provider, where or how would whether the service requested is for IP or OP reported on the PA from the EHR to delegates or payers?
That's a really good question. So again, I'm gonna bring up a slightly different graphic here that will maybe help kind of it's busy, but I think it's pretty straightforward. So when that CRD request is sent from the EHR and goes through a network back through to the payer on the right side, that CRD request goes into this source of truth, and embedded in that CRD request from the payer, excuse me, from the provider, is the information about this procedure. Is it an inpatient, outpatient procedure? And what procedure is it? What is the date of service? It can include the performing or the submitting provider. That rules system at the payer then knows that that procedure code, for instance, is going to be a procedure code that maybe is answered by one of the health plan's medical policies that they host in their system and associated rules, or based upon that procedure code and settings in that source of truth system, the system may indicate that that answer is going to come from a delegated vendor. So that delegated vendor coordination happens on the payer side based upon the information that comes in from the CRD as well as the DTR request when that comes over. And again, the DTR questionnaire itself will also help capture any additional information that's needed to make that determination. In a perfect world, the provider fills out the full questionnaire. That questionnaire is sent over to the payer, and the payer's PAS receiving system can look at the answers to the question and automatically make a decision, yes or no, this is approved. If it's not approved, then of course it's sent on for human review. Our estimations, we've seen automation of prior auths even before we get to DTR of being somewhere in the neighborhood of 50% of prior auths can be automated based upon inpatient, outpatient, other basic demographics. We anticipate that when we get to the policy questionnaires, we're going to see an approval rate of 85 to 90% before we even have to pass that on to a utilization manager or some AI tool. So the rules that are embedded in these three processes, CRD, DTR, are so powerful that before we get to AI on the payer side, we should be able to see 85 to 90% of prior auths automated. Another place where AI may come into place is on the provider side. When that questionnaire is received, as I mentioned earlier, there are codes that can be embedded in that questionnaire that can help, based on FHIR, help the EMR to fill out the questionnaire. And then there are also AI tools that are starting to be delivered that will help answer those questions. I went a little beyond the specific question there, but I think it helped add some context. Any other questions?
It's great. She does have a couple of other follow-ups, and there are some more questions on the chat, but I believe that Keith would be able to handle those in the chat, and we do welcome questions continue to go through the chat. Let's move on to our stakeholder panel, if that's okay.
That sounds great.
Excellent. Let me bring that group up here. All right, we have a fantastic stakeholder panel here to close out this spotlight. Michael is staying as the moderator, and it's my pleasure to introduce the following folks. Please take a couple of seconds to introduce yourself to the audience. Malati, you can go first.
Hey, I'm Malti Subaya. I'm the IT manager supporting Division of Technology Services and DHHS Medicaid for Utah, and actively engaged on implementing the CMS interoperability project.
Fantastic. Welcome back. Chris.
Hello, my name's Chris Smith. I work in enterprise architecture and CMS compliance for the Mississippi Division of Medicaid, focusing on really interoperable solutions, CMS final rules, data sharing, clinical and administrative data exchange.
Excellent. And Kara.
Hey, good afternoon, all. Kara Wayman, Executive Director for Clinical Oversight and Operational Support at HCSC. I am the HCSC Enterprise Business Lead for clinical across all of our markets and our HealthSpring markets.
Excellent. Welcome, everyone. And I'll hand it back off to you, Michael Lunzer, who will be the moderator.
Great. Thank you very much, Robert, and appreciate the opportunity to have a conversation with this distinguished panel. What a great brain trust we have of individuals that have been deep in this topic for some time and have done presentations in other formats. So really excited to have the opportunity to ask a few questions and get your perspective on CMS-0057-F and some of the things that are being required of you. So first of all, I'll ask a question really directed to the entire panel, and that is, how has the CMS-0057-F changed your organization's interoperability roadmap in the past 12 months? And maybe a little also about budget constraints and how those might have impacted what you're doing first. So I'll start by throwing that out maybe to Chris.
Sure. Well, certainly, these rules, these proposed and final rules aren't a surprise because CMS publishes those in advance, then asks for comment. So hopefully nobody was really shocked or surprised when they were finalized and then, put out to the marketplace to be enforced. So we began planning on both 9115 and 0057. And then now hearing that there's more proposed rules coming, we'll be planning for those several years ago. But really, as a Medicaid agency, we can work with CMS and get enhanced funding. So budget wise, we have to work with our state budget and also CMS as a stakeholder to go and plan and build these budgets and these strategic documents, advanced planning documents that we partner with CMS on. To really figure out what we're going to buy, how we're going to implement it, and everything we need. And so it's a bit tricky in the beginning because until the budget's approved with CMS, we can't really procure or go and get anything. So I don't want to say it's a little bit of a guessing game, but we go out to the market, we talk to vendors, we get ballpark estimates, we talk to other states, we go to things like, Medicaid conference and HIMSS and different areas where we can get vendor expertise and really understand, kind of the ballpark of what these things will cost and the impact to the agency as far as personnel, consultants, support, ongoing maintenance and operations. And then we build a strategic plan based around that. So it sounds small, but it's really a lot of work. So it takes 6 months, maybe a year to put all that together and really have an accurate budget to share with CMS and to go out and get the funding for matching funds with CMS.
Thank you, Chris. Malathi, your perspective on interoperability roadmap and budget constraints?
So the CMS mandate has accelerated our plans to create a fully integrated system. We have enhanced our prior authorization workflows and successfully implemented the prior authorization turnaround times. And we are now focused on integrating data. Coming to the second part of your question around the budget constraints, we've had to really focus on the parts of the rules that are foundational and time-bound, which really meant prioritizing the core interoperability APIs and the CMS-specified implementation guide versions that get us to compliance. For example, PASS with CDEX attachments is something that we absolutely want to build, but the final rule was clear that CDEX wasn't mature enough at the time of its publication. So if we pull that forward now, it would significantly impact our workload planning, resourcing, and cost. So this has been deferred, and we will lean towards waiting to hear from CMS on further guidance, on how solicited and unsolicited attachments are to be handled. Another thing that I would say is around the version fatigue with the implementation guides constantly evolving. So it's like if we try to chase every update, we'll probably never cross the finish line. So we are sticking to the CMS's recommended implementation guide versions to ensure we hit our compliance dates on time and within budget. It's all about delivering that core value first so we have a stable platform before we innovate further.
That's an excellent point. We can't let the perfect future get in the way of this huge improvement that's coming from standardizing these transactions and building a different process, getting away from the fax and portals. Kara, would you share a little bit about how CMS 0057 has impacted your organization's interoperability roadmap and how those have affected your budget constraints?
Yeah, I mean, it's aligned with what's already been said. So we were already moving in this direction, right? But this has definitely accelerated our roadmap over the last year. Many of the foundational properties, reducing provider burden, streamlining prior authorization, strengthening utilization management, and really starting to lean in on health data exchange and multi-use cases for health data exchange were things that we were already putting together for our long-term strategy. But what the rule really does is gives us that clear federal expectation and firms up our implementation timeline. So pace definitely changed, but strategy, I would say, didn't change. I think as far as budget and constraints, we really have to be deliberate. And I think that's what everybody else was saying is there is a lot that we want to do, but there are also compliance requirements that are taking the priority right now. And so making sure that we're investing in capabilities that both drive the regulatory compliance and then also are high impact while like starting to phase in our more complex long-term enhancements, like CDEX and using CDEX into those multiple use cases and getting everything into a centralized data platform so that way we can address other use cases. I don't think any of that changes, just the priorities changed a little bit, and then making sure that, this isn't new for any program, but like every penny, we are deliberate in understanding how that is being used and then the return that it brings back to the program and where it brings us strategically as an organization.
Thank you. And I'll go back to you, Kara, with how do you see the commercial and Medicaid strategies diverging at this point? And do you think how aligned are they?
Yeah, so I actually don't see them diverging really. We have the same providers, right? So we have multiple contracts with the same providers across different lines of business. And so if anything, in my experience, and I've been working in the Medicare and the Medicaid space for the last 10 years now. And so if anything, what I see is this pulling us closer together across all of our different lines. The same provider should not have completely different experiences. And so making sure that we have a consistent experience, consistent workflow, the functionality that they have is essential. I think that we have differences which are a little bit nuanced in the commercial space, more so than the Medicare and the Medicaid space. So when we're looking at like group accounts, ASO, benefit configurations can be very, very unique. Referrals and carve outs, like those variations, they're like operational nuances. Again, they don't change our strategy, but there's not a divergence there. It's helping us to try to figure out how do we take something extraordinarily complex and make it simpler for providers and for members to use.
Yeah, that makes sense. Malathi, your thoughts on commercial versus Medicaid variations and things you see that are common and uncommon?
I fully agree with what Kara just said.
Yeah. Chris, any additional thoughts on that?
It's interesting for us because we're mostly managed care and still some fee for service. So I guess I can certainly appreciate where Kara's coming from on that, trying to balance both those worlds and working with them. But certainly, I mean, I think these changes are good for the marketplace, but these are fundamental changes in how work flows and you know work's going to be processed. I mean, some of us people who've been talking about this for the last 20 years have been working on EDI transactions with clinical data, trying to get prior auth to work. So, it's exciting, but also a little bit terrifying, right? That, the rubber's meeting the road right now. And when we talk to our vendors, they say, we've got it mostly figured out. And that gives me some peace. But I think we all need to remember, this is all still new. So we're all working on it. We're all developing it. And I think you have to go in with an attitude of whether you're on the commercial or the Medicare or the Medicaid side, of we're going to figure things out as we go here, and kind of patch the boat as we sail along.
And one thing you mentioned, the fact that you're a fee for service and have a number of MCOs, is the work you're doing within the state of Mississippi really focused on the fee for service side, or are you doing things in your work that are going to help the MCOs downstream as well?
Yeah, we took a totally different approach. We took this opportunity to basically break down silos and create one operational data store. We went with Progress Smart Logic to do that. We're putting everything in there. Kind of sounds like what Kara's doing as well. And then from there, we're going to solve multiple problems out of that. And we decided that fundamentally we wanted all transactions to flow through us. So whether they go to managed care or our fee for service vendor, which happens to be Telligent, everything's going to come through us. All the responses come through us. I think we've struggled a little bit and I'm not saying anything about the fee for service or managed care vendors, but as an organization, we've struggled in the past to hold vendors accountable, no matter what they were, IT or managed care, fee for service. So we're really focused on, moving forward of no more finger pointing. We've implemented things like Dynatrace and Wiz and other security and monitoring and observability tools for our IT vendors. Now we want to make sure that our vendors on these type of transactions and business processes are truly doing what they do. And the only way we could do that is to make a copy and understand what's coming in and going out and being in the middle of it. I know it sounds very antiquated, like a hub and spoke, but really we want to insert ourselves in the middle. We feel like that's the only way we can understand what's happening and truly have control and auditability about performance, support of our beneficiaries. That's what we really care about. Are our bennies getting what they need when they need from these vendors?
That's
so a little bit different approach there.
Yeah, interesting strategy. Thank you for sharing that. Kara, you mentioned that your environment has some extra complexities because of the commercial variations. Where does your scale also potentially create friction that it's not just a financial challenge for you?
I really don't think I wouldn't describe it as friction, right? So I think like as far as scaling, and like I said, like our North Star still remains the same. The provider experience needs to be consistent. But it adds complexity, right? And I think that this interesting thought about, bringing in commercial could add friction. I hadn't thought about it like that, actually. Like to me and for HCSC, we've seen this, again, this was part of our long-term plan anyways, as a chassis for our future, right? And so our commercial book of business is very significant. And so I think a lot of the conversation that's happening today, a lot of conversation we had at HIMSS was, the connectivity and the network. So we need providers to actually use this functionality. Nobody benefits from this. Members, payers, providers, nobody benefits from this if nobody uses this. And so I'm thinking about commercial as that opportunity to bring in the larger network and to bring more providers to the table, and to think about, channel fidelity across not just our FHIR APIs, but also our like our payer portals, right? So that way we have that consistent experience. Commercial doesn't cause friction. It really makes the entire project holistic to me. And I think essentially, if you're putting all of this together, if this is your effort and your intention, it seems silly to me not to bring your commercial business to the table. Because again, if a provider is working in their EHR, and they're used to hitting, submit EFAX, submit EFAX, submit EFAX, and then, you have your one Medicaid member that pops up, and now they're in a new workflow, that's going to throw them off. And so being able to get rid of that submit EFAX just entirely and move over into the API communication with our providers, to me, makes the most sense, I think, strategically, not just for the payers, but for the providers also.
It's great that your organization has made that commitment. It's clear that there's a significant benefit if we all move to this API-based workflow. Malathi, Chris mentioned a little bit about his organization's overall kind of FHIR PA workflow. What impact do you anticipate that your organization's going to see in this category?
FHIR will absolutely streamline our prior authorization workflows. It is a total game changer. Just yesterday, we were speaking to two EHRs who are our high volume prior authorization submitters, and they were quite excited by the fact by how provider access API and the CRD could transform the workflow from what is being tedious today into a data-driven conversation. By surfacing a member's full claim history across all payers with the provider access API, they are going to get a chance to see exactly how many times a CPT code has been billed globally for a specific member in a year. So we are anticipating a reduction in the number of denial prior auths or, submission of prior auths when it's not even needed, right? But 2027 is really just the starting line. The technical infrastructure is one thing, getting providers, payers, MCOs, and our existing enterprise systems all speaking the same FHIR dialect and handling the exceptions gracefully. That's the real work ahead. So yeah, optimistic about the impact, but we are managing expectations that this is a multi-year transformation. It's not a flip the switch moment.
And as you look at that, are there benchmarks or indicators that you're using to assess your readiness of your entire ecosystem?
Yeah, for sure. API uptime, response times, they are kind of very important ones, but I would say the data quality is what determines whether we are actually ready to serve our users. One can have the fastest and the most reliable API in the world, but if we are returning bad data or data that doesn't help the provider make a decision, then we failed. So if an approval comes back missing the authorization number or the denial doesn't explain exactly what documentation was missing, the provider really can't do anything with it. Or in the case of a peer-to-peer API, APIs could be up and fast, but if the consent resource is malformed, technically that integration would have worked, but legally we couldn't honor the consent and the data exchange would have been blocked. So API conformance is a baseline. Passing Inferno is necessary, but it's not sufficient. The payers need to implement the required foundations with R4, SMART, OAuth 2, US Core, the bulk data and all that before Inferno testing becomes even more meaningful. I would think the sandbox availability is a more meaningful early indicator than the production uptime. So yeah, we watch uptime, but we kind of obsess over data quality and a functional sandbox availability.
And as we look at this ecosystem, it's a rather large ecosystem of different participants, both from infrastructure systems and trading partners. How do you evaluate that in terms of whether some are ready and others lag, and what do you do about it in those scenarios?
That's a very good question. So honestly, we manage what we can control, our own APIs and our own readiness. Managing a mixed bag of ready and lagging partners is really where the rubber meets the road. Um, Utah is fortunate to be working with One Utah Health Collaborative. The One Utah effort is focused on bringing payers, providers, HIEs together on a regular basis to share their progress, organization goals, etc. With all that transparency and alignment, sandbox testing and handshake is becoming much easier. Um, but yes, we do not treat all partners as a monolith. We are categorizing them into tiers, and with the first tier being the early adopters, who are really our intermediaries, the HIEs, and the tech forward provider groups. We are piloting with them early, and that's how we are actually making progress towards a CRD only pilot launch in April, the next month. We're kind of going live early with CRD. And our tier two is really the vast majority of our prior authorization providers. And we are working with them to determine who their EHR software owner is, meeting with them, finding out if they are aware of the CMS final rule, educating them, and learning more about their readiness for 2027. Um, and we are also reaching out to all our MCOs, meeting with them regularly, discussing policies and security details, and working on an implementation and integration checklist together. The
And
lagging providers, I think we are just setting clear expectations, providing support, documenting everything. And our existing system is still available. We today fully support electronic submission through our claims interface Prism system. So that's going to continue for the lagging providers until they catch up.
you mentioned sandbox and other kind of testing elements. How is your testing process looking so far, Malathi, and where do you think you are as far as being able to see some early benefits or some successes on the testing side?
Yeah, the HIEs and the tech forward providers are, like what I said, the most actively testing ones. And there are not many as of today, but there are a couple who are ready, and we are actively testing with them now and getting ready for our CRD only pilot launch next month. Initially we were thinking that since we are going on a pilot launch early with CRD only, probably we could think of the next milestone could be the pass subscription layer, pass subscription and polling. But then we found out that major big providers are really not having that feature in their build list for this year. So that kind of, this early testing and strategy discussion helped us find out what the big providers are building as their priorities. And that helped us reprioritize our strategy and our testing plans. For us, readiness to testing with EHRs or providers really means three things. First, that they have a stable environment that implements the CMS required or recommended implementation guide versions that we are all aligning to. Secondly, I would say that they support the core workflows end to end, like member match, consent, the basic pass without constant breakage or version drift. And thirdly, they have the operational capacity, the people, the test data, and the ability to show up consistently in an agile cadence. Um, so, uh, Being ready to test, with our payer and provider partners really means that we've hit three specific milestones in terms of sandbox availability, semantic alignment, meaning data quality readiness, and our OAuth 2 or smart backend services and consent logic are bulletproof.
That's fantastic. Thank you for that. Kara, what are your experiences with testing and where are you at in your process today?
Yeah, I think just speaking for the conversations that I've had is I think it's pretty uneven right now, right? Like the progress that's being made with testing across the industry. I've not seen I personally have not seen any like real robust like end-to-end testing, right? I think like everybody is really heavily focused right now on CRD, which is what makes the most sense to me. I think CRD is extraordinarily complex. I think it is anybody who's not living in this, it's underappreciated how hard it can be. You think that you can just say it's a PA grid. And like I said, I've done a ton of Medicaid business, and you have fee schedules, and maybe something doesn't actually, a claim doesn't look for a prior authorization until it's over a certain quantity limit, right? And now it requires medical necessity justification. And so when you're functioning across multiple states, I think just getting like CRD ready is where a lot of people are focusing on right now. I think April to July is going to be really, really exciting for us. I think, everybody keeps saying the rubber meets the road. It really, really is starting to happen. And I've experienced everything from others just saying like, we can even just start with paper testing if we don't have connectivity today, but the conversation really, really needs to happen. You do not have to have your APIs up and be fully connected to be able to start quote unquote testing. I've had some really incredible conversations with some of our providers, with EHR vendors. Something that I personally have been heavily, heavily involved in is starting to understand and get clear and consistent awareness about the data elements that are going to be expected in the CRD hooks. I think that this is something that we're probably not talking or sharing enough to within the industry. Understanding which fields are required if maintained versus cardinality, and the completeness that we're going to have in those expectations this summer. And just the variations in the hooks, and then the different EHRs and what's being maintained is something that I have prioritized almost over anything else at this point, because I think if we lose our providers in that very, very first interaction and everything says, I don't know, I don't know, I don't know, all of this is for naught, right? And so that, I think, as far as testing, DTR is super exciting to me because I'm a nurse and I love the clinical components, and I hear that from our physicians, and we want to make sure that we get that to them. But if we can't get past CRD and get a really, really strong understanding in the industry for expectations, we're not even going to get to DTR and PAS. So really thinking that, I guess, like, my thoughts for the audience is you don't have to wait to have your full connectivity strategy before you can start engaging and thinking about what does testing look like, or even like how do we just share information, so that way as we are in our development phases, we are all working towards something that is solutionable and everybody's not off on their own, because then we're going to run into some really, really big issues with inconsistency. And again, we're going to lose our providers early on.
That's very great. Good to hear. Thank you, Kara, for your attention to that critical step of making sure that we get it right in each element of the journey so that we don't lose people along the way. Chris, would love to hear about your organization's testing experience and what you're seeing, but I'll add one additional element in terms of provider readiness. What kind of success are you seeing there or not along your testing journey?
Well, as I mentioned, we really took this opportunity to break down silos and rebuild our entire stack, moving from customized Medicaid solutions to SaaS-based COTS off-the-shelf software. So that took us some time. We also had an RFP on the street, which was awarded and then protested by 2 companies in court. So that slowed us down significantly. After that, we decided to use other competitive procurement vehicles to procure COTS-based SaaS software and really rebuild this entire stack. So we're a little bit further behind, but like I said, we're building an operational data store. Everything's going to go in that. We're going to reuse that for multiple business use cases and workflows, processes throughout the organization. So that's up and running. One of the innovative things we did when we're looking for a vendor to build these FHIR APIs, we talked to a lot of vendors in the marketplace, and we're a good partner with AWS, Amazon Web Services. I believe we're the first state to select them. We select them to build these FHIR APIs. They're actually developing a product with us. I believe we're the first state to do that. So AWS is building those FHIR APIs. And then, like I said, we've got vendors like Progress Mark Logic and others, Infor, Cloverleaf, others on the back end really helping us implement that and tear down some of these silos. So as far as testing, we're planning it, we're talking about it, but we're still in the pages of procurement, building, and implementing everything that we need. We believe we have procured, right, and that was by November of last year. So I don't want to say testing is premature. Our PMO does an excellent job of that, and they're planning it out. But kind of my job is to get the money, procure it, bring it all back, and let the really smart PMO and project managers do their stuff. And they're working diligently with our vendors on it. So, as far as providers, years ago we had direct connects with providers to share clinical data. 5 of the largest health systems in the state of Mississippi uses IHE standards for real-time clinical data exchange in CCDA format, XDSB. And so we already had good relationships sharing bidirectionally real-time clinical data with these providers. They're all on Epic, and so we integrate directly into care everywhere. So, we talk with them a lot. We talk to them about moving those connections to FHIR, which we're working on. And then we talk to them about 0057 readiness. So it's an ongoing process. I think it'd be much more challenging if we didn't have those relationships established, both at the business and technical level of these large scale organizations. And we were more of just seen as a payer rather than a trading partner for connectivity and interoperability. I think that would be a bit more challenging. We have had some providers come forward and say, "Hey, we're moving to FHIR. We're certainly very interested in connecting." That's good, but these are mainly large scale, multi-state, large providers who are doing it. We haven't heard a lot from the kind of mid-tier and smaller providers yet on any of this, which I don't know if it's good or bad, but the large keep getting larger, as we all see, and so it's good. We're constantly engaged with them and building roadmaps with them. But as far as some of the other trading partners, it's TBD. And I saw there was a question in the chat about how to engage some of these providers for 0057, and I guess my answer to that as well is, we're working on it. We're trying to get the word out. We're communicating it and trying to, work with everyone, but it takes 2 to tango, right? We're trying to connect fax machines together in 1962. We have to have both sides ready to wire this up. So I don't know that we have any secret sauce on provider engagement, but certainly we will continue to communicate that we want to connect and they can connect directly with us, and continue to work that process. If we figure anything out, we'll certainly share it, but there's no secret sauce, I don't think, at this point.
Yeah, that makes sense. Malatha, where do you see the alignment or the gap between what interoperability is capable of doing and what patients, providers, and other partners expect? And are you seeing a way to address that gap in their expectations or their awareness and what you're capable of doing?
Yeah. So, the way I'm seeing it is the biggest gap now isn't the technology anymore. The APIs work or will work, for the future APIs. The gap is in understanding and adoption. Uh, Patients don't always know what interoperability enables for them. Interoperability has enabled the patient access API, but the adoption rate for third-party health apps amongst the Medicaid members still remains low. Um, a vast majority of the providers, like how Chris mentioned too, are unaware of the final rule. I think it's primarily because they rely on an EHR software or a vendor, and they assume that the EHR software or the owner is taking care of it, and they will let them know whenever the time comes about whatever change is coming. Um, and the EHR vendors are not ready to go into testing mode too before Jan 1st. So I think everyone is waiting to see what another person does, what another provider does. How is it finally going to turn out? So, um, I think that's the biggest gap. Yeah, and as a Medicaid agency, we are doing our best to close that gap by focusing on education. We are trying to take as much time as possible to explain the why as the what, like, why member match matters, why consent is critical, what are the benefits of the patient access API, things like that. And we are following CMS's payer and provider educational resources to enhance our information details that we can share in our MIPS, as well as with our members as a part of their enrollment packet. We are also updating our member portals to make the value visible and the experience usable.
That's great. Kara, when you think about this overall interoperability opportunity, where do you think we're going to see the most benefit if this payer to provider data sharing works as intended? And is that prior authorization? Is it the full scope of payer to payer patient access? Where do you see the impact of this new data sharing concept being the most impactful for you?
Yeah, I mean, I see obviously everybody loves talking about prior authorization right now, but I think where this is really, really going to come together is when we start looking at like HEDIS and quality and risk adjustment and gap closure and the health of our population and being able to surface the right information to our providers in real time. Not as white noise, right? But as this is critical information. We can close the gap right now. We can improve health and we can improve quality of care long term. I think that that's where this will take us if we all lean into it. And Michael, I really apologize. I have a hard stop. So I do have to drop. And I really appreciate the opportunity to be on the panel today.
Great. Thank you, Kara. We really appreciate your contributions.
Thank you.
All right. Chris, what are your thoughts about the impact of interoperability and where we see payer to provider data sharing bringing the most value?
Well, I mean, I think we've been talking about this for 10 or 15 years. Hopefully, we're making some good progress. As I mentioned, in Mississippi, we aggregate rich clinical data from providers as well as obviously paid claims. So, we're really excited about, as I mentioned, building this operational data store and putting everything in it and having the ability to start to really look at the clinical data and the claim data and marry those together and start talking about what Kara was talking about, all the different aspects that you can do once you have the data. I think it's hard, let me tell you this way. Once we started getting clinical data in, we thought, okay, there's one or two use cases we're going to use this for. And then we found 10 more, right? So I think what's exciting to me is once we start getting all the claims data and all the clinical data and other data, LTSS data, other data mixed in there, we can really start to apply specific analytics packages, population health packages, quality packages, right, on top of our operational data store and really start looking for fraud, waste, and abuse, start looking for these use cases that are really important both to the agency that we know and maybe we don't know, right? We've got a very talented MD, PhD data scientist who's just excited to get in there and dig around. And that's encouraged because I think we're going to find different things. We're going to, every use case we have, we're going to find 3 more that somebody else wanted and never could have. So part of this is we're engaging the business users as well to say, hey, what's your dream? What would you want from this data? And people's eyes light up. Well, I could never get it. They'd send me something in Excel. They'd send me this. They'd send me that. Really adding these type of analytics, population health, quality, other very specific, not big bang, specific analytics packages on top of that operational data store with some visualizations, I think gets everyone in the organization excited about the data and the ability to use that data and find more use cases. So like I said, we all have an idea of what we think we want. Once we dig in, there's going to be a lot of opportunity there, but you can't get there if you don't have the data. And I think our panel said it very clearly, right? If you don't trust the data, that's burned us before in the past, right? Bad data, bad analytics, bad results. So data integrity, data quality, but also you first have to get the data, and that's a process, right?
And I have a question on motivation and what makes this time in technology different from past initiatives for interoperability and data sharing. Do you think it's the fact that prior authorization is such a common pain point between payers and providers that that might actually drive this to be the killer use case that gets everybody on board with fire connectivity?
Well, I think these final rules, and then the ASTP, ONC, ASTP, right, making the certifications required on the EHRs, both sides, the carrot and the stick, have not hurt. Having that ability to, I go back to the two fax machines in 1962. We can't just have one side, the payers do this, and then the providers not do it. So to do it in tandem, I think this can be more of a big bang, or at least, the starting gun to get something moving and rolling here. Like I said, I've been working on this a long time. We've been talking about, prior authorization as an EDI transaction and attaching clinical data for 25 years, right? And now we're actually trying to do it. And there are going to be challenges, but we're actually trying to do it. Will that start to get things rolling and sharing data? I think it will. But to my other point, I think once we get into this, we're going to find five more things that we can do with it. And then, I think CMS was very clear earlier in the call. They've got other things coming as well, right? They want to show us what's next. And for Medicaid agencies, this enhanced federal funding and working with CMS is really important for us, because otherwise we wouldn't have the budget, the people, the time, the consultants to do any of this. So I do like the approach that they've included, Medicare Advantage, the payers on the federal exchange, Medicaid agencies, and then the providers, via certified EHRs. That really seems to have shaped up the market. I know there are white spaces still in that group, but that's a very large percentage of healthcare in the United States.
We have time for one last question, which I'll pose to both of you. What can the industry do? Industry, government, partners, what can we all do to assist your organizations as we all continue to implement this rule? What would help move this for you the most? Malathi?
When we started a couple of years ago, we wished we had a standardized, like a TMSIS to fire mapping library or something. With all the 50 states already feeding the same TMSIS data to CMS, we wished there was a shared translator that could easily map our existing enterprise or legacy data into fire profiles. But 2 years later now and closer to implementation, what we think is the most helpful, could be the most helpful, if we could have a national level payer sandbox. With the vast majority of the payers still in the course of development, we are really running out of adequate testing time with all our partner payers in the sandbox environment before going live. So I'm thinking if we have a nice national level payer sandbox that can help all payers across states to verify this asynchronous data exchange, that's something which we've not gotten to see at any of the connectathons or even in the HL7 Foundry. That would be something nice to have. Uh, and amongst a few other things could be if a VD or someone or another organization could help provide a standardized consent language toolkit for all our member states, all our 50 states to have a standard way of saying, do you want to share all your data or do you want to exclude sensitive data, kind of a thing. And any standardized educational assets like videos or infographics that we can embed directly into our portals could be helpful too.
That's great. Thank you. Chris, we've got a minute and a half left. Your thoughts on what can the industry do to assist your organization as this is implemented?
Yeah, I think work groups like WEDI and some of the national conferences we attend, obviously the Medicaid conference and HIMSS, and some of those have been extremely valuable. They have, conferences and work groups and the ability to share information and ask your peers and colleagues how did you figure this out? Also, CMS and ASTP and others attend those conferences, and we can ask them on the record or off the record, what about this and what about that? I think communication, not trying to build this all, in a silo in a black hole, and communicating and learning from what others have done have really, really helped us. I know it feels like you're on your own in this, right? But I've been overwhelmed by people trying to help and reaching out to help. So that's been, whether it's this vendor or that vendor or the price of this, or we're struggling with that. It's really been helpful to work with peers and colleagues and work groups and groups like WEDI.
Well, that's a perfect point to close our discussion, and I thank you for being willing to share where you are in your journey and in your experiences. Because again, as you mentioned, the more folks share their journey, the more we can learn from you and follow along. So with that, thank you, Chris and Malathi, and of course Kara. I'll turn it back over to you, Robert. Thank you for the opportunity for us to have this chat.
No, Michael, thank you. That was a phenomenal discussion. I think extremely helpful for folks on the line here. So I just wanted to take a couple of minutes to thank, first of all, our colleagues and friends from CMS, Scott and David, Michael and Keith from Itiliti Health, and of course, Chris, Malathi, and Kara for sharing their expertise. The only way we're going to get through this is if we do it together. And I think these types of programs where everybody is sharing and working towards a common cause, I think is going to stand us up well to meet that compliance date. But there's a lot of work to do ahead of us, but WEDI is here to help, and the help starts as soon as next week. In fact, one of the topics, Michael, that you discussed was the issue of testing. And we've got a specific program next week sponsored by the Drummond Group, focused specifically on testing and learning about some of the experiences that Drummond has gone through with their fireplace solution. So with that, I just want to again thank you, Michael and Keith and Itiliti Health for sponsoring this program. And big thanks to our Michael McNutt for making things run so smoothly. And with that, have a great rest of the day, and we'll see you at future WEDI events. Take good care.